Hidradenitis Suppurativa, HS. Also known as Acne Inversa or Verneuil's disease. HS word came from Greek hydros equals sweat and aden equals glands. It is a chronic, inflammatory skin disorder of the folliculopilosebaceous units characterized by the development of inflammatory nodules, pustules, sinus tracts, tunnels, and scars, primarily in intertriginous areas. Epidemiology. Estimates of the prevalence of hidradenitis suppurativa have varied, ranging from less than 1% to 4%. The onset of symptoms typically occurs between puberty and age 40, with usual onset in the second or third decade of life. Women are more likely to develop HS than men. Pathogenesis. The pathogenesis of hidradenitis suppurativa is not fully understood, however, new evidence is emerging. As opposed to early theories that implicated apocrine glands as the primary contributors to HS, most authors now support follicle-centered theories for the pathogenesis of HS. Follicular occlusion, follicular rupture, and an associated immune response appear to be important events in the development of the clinical manifestations of HS. Follicular occlusion. It is the most likely event responsible for the initial development of HS lesions. It may be that anoxia within the follicular duct secondary to follicular epithelial hyperplasia contributes to the disruption of normal terminal differentiation of follicular keratinocytes, leading to follicular plugging. Follicular rupture. Follicular rupture may promote the formation of sinus tracts through the release of stem cells from the bulge area of the hair follicle that subsequently proliferate and form epithelial strands. Formed sinus tracts eventually open onto the skin surface and become chronically inflamed. Dysregulation of the immune system. Questions remain about the role of the immune system in HS, particularly whether dysregulation of the immune system is a contributor. A role for immune system dysregulation in HS is suggested by similarities between HS and Crohn's disease. HS and Crohn's disease share histologic features, and there is a well-established epidemiologic association between the two conditions. Moreover, the inflammatory processes of both diseases may respond to anti-tumor necrosis factor, TNF, alpha therapies. Associated factors. Genetic susceptibility, mechanical stresses on the skin, obesity, smoking, diet, and hormonal factors are repeatedly cited as factors that may be associated with the development or exacerbation of HS. Genetic susceptibility. Genetic susceptibility appears to be an important contributor to HS. It is estimated that approximately 40% of patients with HS have an affected first-degree family member. Mechanical stress. Increased mechanical stress, pressure, friction, shear, on intertriginous skin and other areas, for example belt lines, brassiere straps, and other sites of clothing friction, likely contributes to the localization of HS. Mechanical stress on skin has been postulated to contribute to HS via increasing the chance of follicular occlusion and follicular rupture. Obesity. Excess weight is more common in patients with HS than in the general population, however, the disease is not limited to overweight or obese individuals. Smoking. There is a strong relationship between smoking and HS, the majority of affected patients are smokers. Hormones. An impact of hormones on HS is suggested by observations of the rarity of HS in prepubertal children and improvement in HS during treatment with anti-androgenic agents. In addition, some women experience perimenstrual flares, and in this subgroup, amelioration of disease severity during pregnancy was found in a retrospective survey. Bacteria. The role of bacteria in HS is controversial. Cultures from early, unruptured HS lesions are usually sterile. Older and ruptured lesions and sinuses may demonstrate a wide variety of bacteria, for example, Staphylococci, Streptococci, gram-negative rods, and anaerobic bacteria. Coagulase-negative Staphylococci are frequently present. Positive cultures may represent contaminants from normal skin flora or secondary infection. One theory suggests that bacteria may contribute to HS by promoting an inflammatory response, and a role for a bacterial biofilm in the persistence of the inflammatory process of HS has been proposed. Drugs. In support of a contribution of androgens to HS, there are reports of female patients in whom treatment with oral contraceptives containing androgenic progestins, intramuscular medroxyprogesterone acetate, or levonorgestrel in an intrauterine device may precipitate or worsen HS. Lithium therapy has been linked to HS in a small number of patients. Paradoxically, HS has been reported as an adverse effect of anti-TNF-alpha therapies and other biologic treatments given for other chronic inflammatory diseases. Clinical manifestations. Sites. HS predominantly occurs in intertriginous areas. HS can affect the axillae, most common site, inguinal area, inner thighs, perianal and perineal areas, mammary and inframammary regions, buttocks, pubic region, scrotum, vulva, trunk, and, occasionally, the scalp and retroauricular areas. The primary visible lesions of HS are inflammatory nodules. Sinus formation, clusters of open comedones, tombstone comedones, and scarring are the result of recurrent or persistent disease. Inflammatory nodules, most frequently, the first lesion is a solitary, painful, deep-seated inflamed nodule, 0.5 to 2 cm in diameter, often in an intertriginous area. Onset can be insidious, with occasional solitary, painful nodules that can last for several days to months. Recurrent episodes of nodule formation may occur in the exact same location or in the same skin region. Sinus formation, sinus tracts are typical findings in HS that persist for months or years and contribute to symptomatology. The development of multiple recurrent nodules within a limited area may predispose to the formation of intercommunicating sinuses. Patients with sinus tracts often experience intermittent release of blood-stained, seropurulent, malodorous discharge. Clusters of open comedones, tombstone comedones. Open comedones often appear in long-standing HS, commonly as double-headed or multi-headed open comedones. These structures are often described as tombstone comedones because they reflect end-stage damage to the folliculopilosebaceous unit with associated loss of the sebaceous gland and hair. Scarring. The appearance of healed areas ranges from individual, pitted, acneiform scars after resolution of small nodules to dense, fibrotic bands or indurated, thick, scarred plaques affecting the whole affected area. Clinical staging. The Hurley clinical staging system frequently is used to divide patients with hidradenitis suppurativa into 3 disease severity groups. Stage 1, abscess formation, single or multiple, without sinus tracts and cicatrization or scarring. Stage 2, recurrent abscesses with sinus tracts and scarring, single or multiple widely separated lesions. Stage 3, diffuse or almost diffuse involvement, or multiple interconnected sinus tracts and abscesses across the entire area. Associated disorders and syndromes. Emerging data indicate that patients with HS may have increased incidence of, and risk for, metabolic syndrome and related comorbidities, a constellation of metabolic and secondary disorders including diabetes, obesity, insulin resistance, dyslipidemia, hyperglycemia, and hypertension. Several studies suggest an association between HS and inflammatory bowel disease. Acne vulgaris is a common condition that may be seen in association with HS. Follicular occlusion tetrad. The follicular occlusion tetrad consists of 4 diagnoses: HS, acne conglobata, dissecting cellulitis of the scalp, and pilonidal sinus. These 4 conditions are considered to share follicular occlusion as a key pathogenic event and may appear in conjunction with one another in individual patients. Popash syndrome, pyogenic arthritis, pyoderma gangrenosum, acne, and suppurative hidradenitis, has been described in an adolescent in whom a mutation in the STPIP1 gene was detected. The term PASH syndrome has been used to refer to patients with pyoderma gangrenosum, acne, and suppurative hidradenitis. Histopathology. The histopathologic findings in HS vary according to the stage of the lesion. Common early features include follicular hyperkeratosis, follicular plugging, follicular dilation, and lymphocytic perifolliculitis. Biopsies of established areas of disease can demonstrate additional features, including psoriasiform hyperplasia of the interfollicular epithelium or a dense, mixed inflammatory infiltrate involving the lower half of the dermis and subcutis. In addition, chronic abscesses, sinus tracts lined by stratified squamous epithelium, and granulation tissue with or without foreign body giant cells may be present. Destruction of folliculopilosebaceous units, fibrosis, and incidental periapocrine and periecrin inflammation also may be evident. Diagnosis. The diagnosis of hidradenitis suppurativa is made from the patient history and recognition of characteristic clinical manifestations. History and physical examination. The 3 main clinical features that support a diagnosis of HS are as follows. Typical lesions: multiple deep-seated inflamed nodules, tombstone comedones, sinus tracts, abscesses, and fibrotic scars. Typical locations, in particular, axilla, groin, inframammary areas, often bilateral distribution, and relapses and chronicity. Laboratory studies. Skin biopsy. Skin biopsy usually is not necessary for diagnosis. However, in cases in which the diagnosis is uncertain, a biopsy can be useful for excluding other disorders. A biopsy should also be performed if features suggestive of squamous cell carcinoma, SCC, are present. Bacterial cultures. Routine bacterial cultures are not indicated. Cultures are reserved for cases in which the clinical findings are suggestive of a primary infectious disorder rather than HS, or if there is clinical evidence of secondary cellulitis. No serologic studies confirm a diagnosis of HS. Imaging. Radiologic imaging is not necessary for the diagnosis of HS. However, ultrasound may be useful for preoperative assessment of the subclinical extent of disease. Magnetic resonance imaging may be helpful for delineating extensive anogenital disease. Differential diagnosis. A few diseases produce inflamed nodules, recurrent abscesses, or sinus tracts that may be mistaken for hidradenitis suppurativa. The patient history and clinical findings are usually sufficient for distinguishing from other diseases. These conditions are follicular pyodermas, folliculitis, furuncles, carbuncles, acne vulgaris, intergluteal pilonidal disease, Crohn disease, granuloma inguinal. Other disorders that may enter the differential diagnosis of HS include actinomycosis, anal fistula, cat scratch disease, cellulitis, inflamed epidermoid cyst, ischiorectal abscess, lymphogranuloma venereum, nocardiosis, nodulo-ulcerative syphilis, perirectal abscess, tuberculous abscess, and tularemia. Complications. Long-standing, poorly controlled hidradenitis suppurativa may lead to significant physical and emotional consequences. Complications include strictures and contractures, lymphatic obstruction, lymphedema of limbs and genitalia, malaise, depression, and suicide. Long-term effects of chronic inflammation including anemia, hypoproteinemia, and amyloidosis. Infectious complications, for example lumbosacral epidural abscess, sacral bacterial osteomyelitis, arthritis, squamous cell carcinoma and anemia. Treatment. Treatment goals. Interventions for HS target one or more of three major goals. To reduce the frequency of new lesions, minimizing pain and suppuration. To prevent disease progression by limiting the formation of scarring, and to treat existing lesions and scarring, a goal which may require a combination of medical and surgical intervention. More than 50 interventions exist for treatment of HS, including patient self-management strategies, topical therapy, oral systemic agents, biologic therapies, surgery, and laser and light interventions. Disease severity, patient tolerance of specific agents, comorbidities, and treatment cost and availability guide treatment choices. General approaches. Regardless of disease severity, attention to patient education and support, patient self-management, management of comorbidities, and pain management may be beneficial. Education and support. Because HS is a psychologically distressing disorder that can have a major impact on patient quality of life, patient education and support are essential components of management. The clinician should inquire about the impact of the disease on the patient's quality of life and assess for symptoms of depression. Self-management. Patient self-management is an important part of the approach to HS. Patients should be offered individualized self-management strategies. Avoidance of skin trauma. Factors that promote skin maceration and follicular trauma may contribute to worsening of HS due to the promotion of inflammation, follicular occlusion, and follicular rupture. Advise patients to wear loose, light clothing and to actively avoid excessive heat, friction, and shearing trauma. Washing with loofahs or brushes should be avoided to prevent unnecessary skin trauma and irritation. Dressings. Whether dressing untreated but actively draining lesions or the postoperative wound, dressings should be selected that minimize skin trauma. To prevent absorbent dressings from sticking to the wound, simple white petrolatum can be applied. Adhesive tape should be avoided, and instead, elastic fishnet dressings can be customized to hold absorbent material in place. Smoking cessation. Smoking is commonly associated with HS. The case for smoking as a causative factor is strengthening, and documentation of improvement in HS after smoking cessation has appeared in a few case reports. Weight management. As with smoking, excess weight has been linked to HS, but a causative association between weight and HS has not been definitively established. Factors related to excess weight, such as skin occlusion, skin friction, shearing forces on skin, hyperinsulinemia and other hormonal changes that can occur in association with excess weight, and dietary factors appear to be contributing factors in HS. Thus, physicians encourage and support weight management in our HS patients. In addition, physicians sometimes prescribe metformin, an anti-diabetes drug that may be beneficial for HS and may have a modest effect on weight loss. Antiseptics. Topical antiseptic washes such as chlorhexidine 4% may be helpful for HS. Chlorhexidine can be used for showering, beginning with once per week use and increasing up to once daily as tolerated. In addition, some patients find emollients containing benzalkonium chloride, an antimicrobial agent, to be helpful. Management of comorbidities. Patients with HS may be at increased risk for alcohol dependence, arthropathies, autoimmune conditions, cardiovascular risk, diabetes, drug dependence, dyslipidemia, follicular syndromes, hypertension, lymphoma, malignancies, metabolic syndrome, nicotine addiction, obesity, polycystic ovarian syndrome, psychiatric and psychologic disorders, rheumatologic conditions, and thyroid disease. Multidisciplinary management of comorbidities can improve patient outcomes. Pain management. Pain from HS nodules and abscesses may cause sleep disturbance, limit function, and induce psychologic distress. Nonsteroidal anti-inflammatories can be used to treat both pain and inflammation. Additional analgesia, including opioid analgesia, may be needed. Early stage 1, mild disease. Local therapy combined with the general approaches is the preferred treatment of mild HS. Useful local measures include topical clindamycin, intralesional corticosteroid injections, punch debridement, and topical resorcinol. When these measures are insufficient, oral tetracyclines may be beneficial. Early stage 2, moderate disease. Antibiotics, oral retinoids, hormonal therapy, and surgery are treatment options for moderate disease. Antibiotic therapy. The mechanism by which antibiotic therapy improves HS has not been definitively determined. Antibiotics may help to control skin bacterial load, however, the anti-inflammatory effects associated with some antibiotics may also play a role. First-line antibiotic therapy includes oral tetracyclines, clindamycin, and rifampin, dapsone, erythromycin and cephalosporins. Oral tetracyclines. Tetracyclines are a key treatment for mild to moderate HS, in part because of their favorable adverse effect profile. Common regimen for adults is 100 mg of doxycycline given once to twice daily. Alternative tetracycline regimens include limcycline, 408 mg once or twice daily, tetracycline, 500 mg twice daily, and minocycline, 100 mg once or twice daily. Treatment is generally continued for several months. Clindamycin and rifampin, combination therapy with clindamycin, 300 mg twice daily, and rifampin, 600 mg once daily, for 10 weeks. Is an option for patients who fail to respond to oral tetracyclines. Other antibiotics, dapsone may be effective in mild to moderate HS, particularly in the early neutrophil-mediated phase of new lesions. Erythromycin and cephalosporins have also been used for long-term antibiotic therapy. Oral retinoids, acitretin, isotretinoin, and a newer oral retinoid, alitretinoin, have been used to treat HS. Acitretin is the primary agent utilized. Isotretinoin remains the gold standard treatment for severe acne vulgaris and is often used to treat concomitant acne in HS patients, however, it appears to provide only limited benefit for HS. Hormonal therapy. Androgens may contribute to the development of HS. Examples of anti-androgenic therapies that may improve the disease include cyproterone acetate, oral contraceptive pills, spironolactone, and finasteride. Surgery. Surgery can be used for the treatment of individual nodules and sinus tracts that occur in any early stage of disease. Punch debridement, limited deroofing unroofing, of fresh lesions or deroofing of single nodules and extensive sinuses is usually sufficient. Wide excision is typically reserved for early stage 3 disease. Early stage 3, severe and refractory disease. Both medical and surgical therapies are utilized to prevent the development of new lesions and to treat existing lesions in patients with refractory early stage 2 HS and early stage 3 HS. Medical therapy. TNF-alpha inhibitors. Patients who do not respond sufficiently to oral antibiotics, oral retinoids, or hormonal therapies may benefit from biologic treatments, in particular, adalimumab, initial 160 mg subcutaneous dose, given at one time or split into 280 mg doses given over 2 consecutive days, then 80 mg on day 15, then 40 mg once weekly starting on day 29, or infliximab. Conventional immunosuppressants, occasionally, systemic glucocorticoids, prednisone 40 to 60 mg per day, tapered over the subsequent 7 to 10 days, or cyclosporin, 2 to 3.5 mg/kg per day for 0.5 to 24 months, are prescribed for HS, However, evidence on the efficacy of these treatments for HS is limited. In addition, because these drugs may induce severe adverse effects, they are rarely utilized for long-term therapy. Emerging therapies: ustekinumab, an interleukin-12/23 inhibitor, and anakinra, antagonist of the interleukin-1 receptor, are newer biologic therapies that may be of benefit for patients with severe and refractory HS based upon limited data. A case report also describes a potential response of HS to oral tacrolimus. Surgical therapy. Surgical procedures may be performed on individual nodules or sinus tracts, and in severe cases may be used to excise an entire affected area. Surgery should not be used in isolation. Combining surgery with medical therapy provides the best chance for preventing the development of new lesions and controlling disease progress. The surgical approach generally becomes more aggressive with higher stage disease. Other non-surgical therapies. Other non-surgical therapies may be useful as adjunctive or alternative therapies, includes metformin. Insulin and insulin-like growth factor may contribute to HS, providing a potential underlying mechanism for a beneficial effect of metformin in HS, along with possible weight loss. Oral zinc, due to its anti-inflammatory and anti-androgenic properties. Laser therapies with 1064 nm neodymium-doped yttrium aluminum garnet, NdYAG, laser, possibly due to follicular destruction or dermal heating leading to the disruption of the inflammatory infiltrate. Photodynamic therapy, which combines use of a photosensitizer and a light source to induce cellular destruction through porphyrin activation. External beam radiation. Botulinum toxin. Fumarates. Cryoinsufflation. Cryoinsufflation, a procedure in which liquid nitrogen is injected directly into HS sinus tracts, has been reported as effective in 2 patients with early stage 2 HS. Vitamin D3. Vitamin D3 supplementation has been proposed as a treatment for HS based upon hypotheses that a deficiency in innate immunity may contribute to HS and that vitamin D3 may play an important role in innate immunity. Thank you.